Hello everyone, welcome to my channel Surgery Nuggets by Dr. Himasri. Today's topic of discussion is Hirschsprung disease. Hirschsprung disease is a common cause of intestinal obstruction in newborns. It results from absence of ganglionic cell in the mesenteric plexus of the intestine. As you can see in this picture, Hirschsprung disease can affect any part of the intestine, any length of the intestine. The long segment Hirschsprung disease, which is seen in 15% of cases, is the aganglionosis from sigmoid colon descending colon junction up to the cecum. Ganglion cells are present in the colon, which is most common, seen in 72 to 75% of patients. Here, aganglionosis is to the sigmoid colon descending colon junction. If aganglionosis of the entire colon extend up to less than 5 cm of terminal ileum, it is called total colonic Hirschsprung disease, seen in 8 to 10% of the patients. Sometimes it can extend beyond the terminal ileum, that is more than 5 cm of terminal ileum is involved, which is seen in almost 5% of cases, called small intestinal Hirschsprung disease. Less than 20 cm of ganglionated intestine beyond the ligament of Treitz is also sometimes involved, seen in less than 1% of cases, which is very rare. Now, coming to the incidence of Hirschsprung disease, it is seen in 1:5,000 live births. Males are commonly involved. Male is to female ratio is 4:1. But we have seen for long segment Hirschsprung disease, the ratio is almost 1:1. 4 to 12% of cases associated with Down syndrome. As we have already discussed in the previous picture, Hirschsprung disease may extend from anus to sigmoid colon in 75% cases, proximal colon in 15% cases, and terminal ileum involved in 8 to 10% of patients. Coming to the pathophysiology of Hirschsprung disease. Genetic defect is the proven cause of Hirschsprung disease. Most commonly, RET oncogene endothelium signaling pathway genes, for example EDNRB, EDN3. These two genes can affect the migration of the neuroblast during the gestational period. That is, neural crest derived intestinal neurons now cannot move caudally. So, neural crest derived intestinal neurons migration is affected because of these genes. So, what will happen? It will lead to aganglionosis of the distal bowel loop. There is no nerve cells in the distal bowel loop, aganglionosis. And also there is thickened nerve trunk in the distal bowel loop. So there will be thickening of the nerve fibers in the distally affected segment of the bowel loop. These things will eventually lead to functional obstruction, because now the bowel cannot fail to relax in response to stimulus, leading to functional obstruction, and the proximally dilated bowel loops are seen. So bowel loop fail to relax. So this is the diagram. This is a normal diagram of colon. These yellow dots you can see are indicating ganglion cells. But in Hirschsprung disease, these ganglion cells are absent in the distal part. So there is no ganglion cell and the affected part is collapsed. Proximally there is a transition zone and proximally bowel loops are dilated. Coming to the clinical features of Hirschsprung disease, most common is failure to pass meconium in the first 24 hours of birth, constipation seen in older children, abdominal distension is common, bilious vomiting, refusal to feed, and around 10% of cases present with Hirschsprung associated enterocolitis. So here what happens? The children with Hirschsprung disease may present with fever, abdominal distension and diarrhea due to Hirschsprung associated enterocolitis. So what are the features? Number 1 is fever, abdominal distension with diarrhea. So this is called Hirschsprung associated enterocolitis. Next, investigation. Plain X-ray abdomen is most commonly done as a first investigation. It will show us gas-filled intestine with dilated proximal bowel loops. So main features are gas-filled intestine, and bowel loops are dilated. So there is dilatation seen in whole extent of the colon. Another important investigation is barium enema. Barium enema is almost 80% accurate. It shows a junction of aganglionic and ganglionic intestine. So there will be proximally normal ganglion cell. This is the junction between the normal and abnormal intestine. Funnel-shaped dilated bowel loops are seen. This is called transitional zone, which is characteristic feature in barium enema. Another useful investigation is anorectal manometry. Anorectal manometry is useful for evaluating older children with chronic constipation. Coming to the gold standard investigation, it is cot-site full thickness suction rectal biopsy. Rectal biopsy is almost 95% accurate. So what are the features on rectal biopsy? It shows absence of ganglionic cells, increased staining of acetylcholinesterase, and hypertrophic nerve bundles are also seen. Another important investigation nowadays is calretinine. So what is calretinine? It is a immunohistochemistry marker used for confirmation of Hirschsprung disease. So this is a radiological investigation diagram showing the dilated bowel loops, gas-filled abdomen. Here you can see in the next picture, you can see the black arrow showing the junction between the normal and abnormal intestine, the collapsed bowel loop, and proximally distended bowel loops. Next diagram is showing suction biopsy. The first one is normal rectal mucosa, but in the second picture you can see there is increased acetylcholinesterase staining in the biopsy segment of rectal mucosa. Below is another diagram. This is the rectum, anal canal, and there is one transitional zone and showing absence ganglionic cell and acetylcholinesterase staining. Coming to the treatment part, the most common is primary pull-through operation without a colostomy. At around 3 months, definitive pull-through surgery is done, and till that point, mother is taught rectal irrigation. So what is rectal irrigation? Rectal irrigation is done with normal saline. So with normal saline at the rate of 10 to 20 ml per kg body weight every 8 to 12 hours. Mother is taught to clean the rectum of the child and using a 10 to 20 size ICD tube. So it is basically done 2 to 3 times daily to clean the rectum using a ICD tube. Another common option is colostomy in the newborn period with definitive pull-through operation at later date. Classically, 3 pull-through procedures are used: Swenson, Duhamel, and Schwab's endorectal surgery. So the first diagram is showing Swenson surgery. It is the original pull-through procedure. Here what happened? The aganglionic, that is below part, aganglionic part of the bowel is resected, and the upper part with the yellow dots, that is the normal ganglionic part. That normal part is then pulled through and anastomosed with the low rectum, and abnormal part is resected. So this is Swenson surgery. Second diagram is Duhamel surgery. So Duhamel surgery is basically a modification of Swenson surgery. Here the aganglionic bowel is resected down to the rectum, and the proximal bowel is brought through the retrorectal space, and one end-to-end anastomosis is performed with the remaining rectum. The third diagram is Schwab's surgery. So here what happens? The mucosa and submucosa is resected. The ganglionic bowel is then pulled through the aganglionic muscular cuff of the rectum. Here you can see this is the muscular cuff of the rectum, and the ganglionic part, the part with the yellow dots, that is the normal part, is pulled through the muscular cuff of the rectum and anastomosed. So the mucosa and submucosa is resected here. Another diagram showing the pull-through techniques. The first one is Swenson pull-through technique, where the upper part is the normal ganglionic bowel, then there is transitional zone, then the lower part is aganglionic bowel rectal mucosa. So Swenson pull-through technique involves full thickness dissection of the rectum and then eversion of the rectosigmoid stump. The proximal ganglionated bowel is grasped and brought down to the anus and anastomosed. Picture, those are the Schwab's procedures. The last one, you can see there is a muscle cuff around the ganglionic bowel loop, as I have already mentioned in the previous slides. Laparoscopic transanal dissection is also very common. Robotic surgeries are also performed. This is another diagram showing the radiological investigation. X-ray abdomen with dilated bowel loops, intra-finding transanal procedure is done here, and this is the resected bowel segment with dilated proximal and distally collapsed bowel loop. So what are the post-op complications? Most common is Hirschsprung associated enterocolitis, as I have already mentioned, seen in around 25% cases. Fever, shock, vomiting, etc. are also seen. Risk factor for Hirschsprung associated enterocolitis. Let's discuss it, because the mortality rate is very high, almost 33% mortality seen in HAEC. So what are the risk factors? Number 1, if there is delay in the diagnosis of Hirschsprung disease. Delayed diagnosis is associated with increased mortality rate. Second is increased length of aganglionic segment. The length is also related to high mortality. Another important factor is if child is having other comorbidities or genetic defect like Down syndrome, genetic syndromes like Down syndrome, then also risk factors for HA, Hirschsprung associated enterocolitis, increases. Thank you everyone. Please subscribe and like for more such videos. If you have any doubt, kindly post in the comment section. Thank you so much.